And this happens because the blood pressure is dropping more than 20 points upon standing. That's that orthostatic hypotension. And the heart rate does not rise. So if somebody is dehydrated but their nervous system is working appropriately, or even if somebody who doesn't have NOH is out in their garden and they're squatting and they stand up and they get a little bit of dizziness for a second or two, the heart rate will typically kind of kick up the pace to match that low blood pressure to get the blood pressure, the blood back up to the brain. Essentially, all of the symptoms come from not enough blood flow to the brain. But this is not like a stroke where there's a blood clot or a narrowing of an artery. This is that the general brain, the whole brain is not being given enough blood flow because the blood pressure is too low to support it. So the difference between this and that whole, oh, I stood up too quickly and I got a little dizzy, is that it takes a minute or two after standing for this drop to occur. And that's a key differentiating factor between NOH and other causes of orthostatic hypotension. And the difference is that if your blood pressure, and sort of why it's dangerous, is that if your blood pressure drops or you feel a little woozy right after standing up, then you take a moment, you brace yourself, you sit down, you lean against whatever it was that you were next to or on, and you can catch yourself. But if you get up and you feel fine and you walk away for a minute or two, then you might be out in a clearing somewhere or in the parking lot or what the case may be, or going up a flight of stairs, and then all of a sudden the blood pressure is dropping, and then all of a sudden there's nothing for you to hold on to, so you might have more trouble with falling or near falls and injuries in that regard. The other symptom, I should say the other manifestation of NOH is that the blood pressure can go quite high lying down, and that may not cause symptoms, but it can be quite dangerous for the general health of a person and the risk of stroke, and that is what we call supine hypertension. So in order to check for NOH, you'll need a blood pressure cuff, and this is often done in the doctor's office, but a lot of my patients, I ask them to purchase a blood pressure cuff so that they can do that at home on a frequent basis, like every day. This, please don't mistake that as an advertisement for that particular brand, but there are many blood pressure cuffs that are available for 25 to 30 bucks. They can be bought at any local pharmacy or online on Amazon or what have you. And the only thing I recommend against is the wrist cuffs. I feel like they're not quite as accurate as the ones that go around the arm, the upper arm. But they're automated, very easy to use. So what you'll want to do is lie down for about 5 to 10 minutes, and then after that 5-10 minute period, check your blood pressure while lying down, or have somebody do it for you. Then you're going to sit up. Wait 2 full minutes. Don't do anything in those 2 minutes. Just sit there for 2 minutes. Then check your blood pressure then. Write that down. And then stand up. Wait for 2 full minutes. Don't walk around. Don't go anywhere. Just stand for 2 minutes and then check your blood pressure and write that down as well. Sorry. So there should be 3 measurements. What normally happens is that there's a little bit of a drop of less or no drop at all for less than 10 or 20 points on the top number, the systolic number. In orthostatic hypotension, the drop is more than 20 points, and it can be quite dramatic, including I have some people whose lying down blood pressure runs in the 180s to 200s over 90s to 110s, and then they stand up and their blood pressure runs in the 60s to 80s over 40s to whatever. So extremely large differences between lying down and standing, which can be extremely tricky to treat. What I've seen people make mistakes with is they'll do this in the wrong order, or they'll do it like where it's an hour later, which is not valid. So you want to do it in that time frame right at that 2-minute mark or right after that, 5-minute mark of lying down. I do recommend if you are taking medications for blood pressure, whether it's raising or lowering your blood pressure, that you do this this whole routine about an hour after you're taking your blood pressure meds. And I also recommend that you do it around the same time every day, because there can be quite a variability from day to day. For some people, it's not quite as variable, and then they can sort of taper down to checking it every other day or even once a week. But if it's happening frequently, if it's an issue, then a daily check is useful. And the other thing, the other sort of pitfall or the error that I've seen people make is like, oh, well, I got really dizzy, but I couldn't check my blood pressure at that point because, I was about to fall. I'm like, be safe. Don't try to do, don't try to stand up if you are falling down. But this isn't necessarily going to be for when you're feeling symptomatic. It can be at the times of day that you're not feeling symptoms, but then do keep a note of if there are days that you're having symptoms so that we have a sense of what is the minimum blood pressure that you can tolerate. Because as you probably know, there are people walking around with blood pressure in the 90s and they have no symptoms whatsoever. So we don't want to worry about a low blood pressure that people are tolerating. This is just in case people want to see that in a verbal form. I have a log that I give people to use. It gives me information. What I will say is that, as you'll see here, that the pulse is also noted, and for the vast majority, the pulse does not change. So I don't necessarily ask people to write down the pulse, but if they're seeing differences in the pulse, then they can keep a log of that. If that's not enough, or the question is still unclear whether something is truly neurogenic or not, because sometimes Parkinson's patients have cardiac issues or have dehydration or other things, then there might be other tests that can be recommended, including an evaluation by a cardiologist who specializes in autonomic testing, or a neurologist who specializes in autonomic testing. And a few things that can be looked at, like EKG, the sweat response, deep breathing, and then looking at your heart rate as you're deep breathing, because there's normally supposed to be a variation in that. And then bearing down, there's supposed to be a variability in the heart rate and the blood pressure with that bearing down kind of response. And then finally, a test that's called the tilt table test, which is where they kind of strap you to a table lying down, and then they'll gradually increase the incline to close to standing. And as they're doing that, they're looking at your heart rate and blood pressure. So if the diagnosis has been established, then we have to talk about how to manage it. And for the majority of people, we want to emphasize non-medication treatment. So drinking water daily, small frequent meals, because having a very large meal can sometimes cause the blood to rush to the gut, lowering the blood pressure. For many people, a cup of coffee a day can help. Be sure to avoid stressors like heat, hot yoga. Obviously we always hear about people in their 70s and 80s fainting at college graduations out in the heat. There is some data to recommend wearing an abdominal binder, which is pictured on the bottom right there, where it kind of keeps the blood flowing back to the gut, and then that will get the blood flowing back up to the brain. Not quite as good data on wearing the compression stockings, but they're worth a try. A lot of my patients complain that they're hard to get on, so I do suggest trying the zip-up stockings. And then at night, if the blood pressure is too high at night, if there's supine hypertension, then keeping the head of bed up 30 degrees at night will prevent those high highs. Constipation is also an important thing. Again, everything's connected to each other, but the idea is that constipation can then cause people to have to bear down hard to have a bowel movement. Like if you're straining to pass stool, then that can be can set off a low blood pressure, and people can pass out while they're defecating or urinating, which is not a pretty sight. So trying to make sure that you're on top of constipation so that you're not straining when you're passing stool is important. Other things that can help is getting up slowly, sitting, especially when you've been lying down for a while or if you've been sitting down for a while. So sit on the edge of bed for a few minutes and then squeeze your hands, open and close fists for about 5 times. And then it's hard to show because I don't have the video here, but going up and down on the so you're sitting down, not standing, but you're sitting down. You keep your heels down, lift your toes up, and then put your toes down and lift your heels up and sort of go up and down like this with your feet for about 5 times each. That gets the blood flowing back. So you kind of want to squeeze your calves to get the blood flowing back. What people may not know is that we don't have any artery support in the walls of our veins, so they rely on these kind of flimsy valves. And as people know, when they've developed varicose veins, those valves will essentially fail on all of us eventually, and so then the blood starts to pool in the legs. So when the blood's pooling in the legs, then it's not getting to the heart and not getting to the brain. So you want to squeeze the muscles around the calves. That gets that blood flowing back. And then upon rising, wait a moment to get your bearings. And it might be more than a moment, it might be 2 minutes of standing by something or having the walker if you have one, or railing or what have you before walking. During the day, it's important to not do too much time lying down if you have supine hypertension, and exercise daily. And then a lot of people develop supine hypertension because they're taking orthostatic hypotension because they're taking medications that can cause it. So simplest thing is to look at that med list and make sure that we've taken off meds that can cause it. And that can include alcohol, but probably the biggest offenders I see are people like men who are taking medications for their prostate. So Flomax and Hytrin are what are called alpha blockers. Some antidepressants, some blood pressure medications can do it. Certain antipsychotic medications, muscle relaxants, narcotics, Viagra, sedative, like sleeping pills, like temazepam. And then anything that opens up the blood vessels. So if you're taking it for blood pressure or if you're taking it for heart disease, again, I'm not suggesting that anybody, please do not, take this as medical advice, and do not suggest that anybody stop taking any medications today. But if you see anything that you're taking that's on this list, do make a note of it and just discuss it with your cardiologist or your neurologist or your primary care doctor if you are having symptoms of orthostatic hypotension. But please don't take any medical advice from this discussion today. And then this is a little bit of a busy slide, but it gives us a sense of sort of that complex dance that is involved in maintaining our blood pressure, not too high, not too low, with positional changes such as lying down, sitting, and standing. And this is kind of where things don't work as well in people who have NOH. So what we have is 2 nerve cells, and that's represented, I don't know, can you guys see my mouse? Yes? Okay, you're nodding. Okay, so these yellowy looking things are nerve cells, or we call them neurons. And each nerve cell releases chemicals that are called neurotransmitters, and then they act on the next nerve cell, and then those chemicals act on receptors at the blood vessel. So constricting or opening them to control blood pressure. So receptors are kind of like a lock, and the neurotransmitters are the key. So the ones that we talk about are acetylcholine, which is abbreviated ACH, and norepinephrine, which is abbreviated NE. So we see that we have a few of the players that you may have heard about or may be taking involved midodrine, fludrocortisone, droxidopa, and pyridostigmine. We'll talk about those, but that's the idea. And this is sort of the flip of it, is why that prior slide about the offending meds are problematic, because this receptor is called the alpha receptor, and the Flomax we talked about is an alpha blocker. So it blocks this receptor and it opens up that blood vessel, where what we want is to constrict it to I'm using my hands, you can't see them, sorry, you know, to make the blood flow. So these are the commonly used medications for NOH. So midodrine is also known as proamotine. As I mentioned, what it does is it acts on the alpha receptor, and it constricts the blood vessels. And because it constricts blood vessels, it can worsen or cause supine hypertension, which is when the blood pressure is too high lying down. And it can also cause the bladder not to empty properly. So that's a concern that should be evaluated periodically. So whenever you're taking medications for NOH, you do want to be really good about keeping that log, because we're not just looking at your symptoms, we also want to make sure we're not creating too high blood pressures lying down. This can be taken 1 to 3 times a day at a range of 2.5 to 10 milligrams. The next one is Florinef, which is fludrocortisone, and what this does is it makes your kidney hang on to salt. So when you retain salt, it increases the fluid in the blood vessels, and that can boost the blood pressure. It's taken once a day, 0.1 or 0.2 milligrams. Also can cause supine hypertension, as well as low potassium and swelling. And that swelling can be in the legs, but it can also cause cardiac problems, meaning pulmonary edema. So fluid backing up in the lungs. So again, anytime we're talking about these kinds of medications, we also want to make sure that we've verified with the cardiologist or with the primary that that's okay to give. The newest medication for orthostatic hypotension is called droxidopa or Northera. This one, again, going back to that slide to show where it acts, this one acts on norepinephrine by boosting its utility in the connection between the nerve and the blood vessel, and it also boosts it in other tissues as well. So therefore, it can, again, create more, constrict the blood vessels a little bit, create a little bit of a higher blood pressure. The good news with Northera is that it's a lower risk of developing the supine hypertension. Side effects can include headache, nausea, and dizziness. And this one's taken 400 to 600 milligrams 3 times a day, but you start with 100 milligrams 3 times a day. You work your way up fairly rapidly to get to that dose. And then finally, there's pyridostigmine, which is mestinon. This one is back here, it works by boosting the acetylcholine and thereby acting on this communication between the preganglionic nerve cell and the ganglion nerve cell. But because it kind of works earlier in the process, if you will, it can have other side effects, such as actually making you urinate more frequently. You know, it sort of activates that parasympathetic system we were talking about. So going to the bathroom more frequently, which might be a good thing for Parkinson's patients. It can slow the heart rate down. So it's a little bit, it needs to be taken with caution, especially if there's any cardiac issues or cardiac meds that slow the heart rate down as well. This one can be taken 2 to 3 times a day as a 30 to 60 milligrams, or there is a long-acting form that's once a day, 180 milligrams. Less commonly used medications for NOH include caffeine and salt. So all of the things that your doctors told you, no caffeine, no salt, you can sort of throw that out the window. You know, of course, don't misconstrue this as medical advice. Make sure that your doctors are signing off on this. I don't recommend doing salt or caffeine without the supervision of a doctor. But the thing about salt is that I've seen people tell me, at least in Southern California, a lot of our patients are like, oh, I eat so healthy. I cook everything from scratch. And then I ask them, do you add salt? And they're like, no, I stay away from salt. And then when you think about it, if you're really truly cooking from scratch, there probably isn't enough salt in your diet. So that's something where, you know, just adding salt to a normal amount is important. But for some people, they'll actually recommend more than the normal amount. So a normal amount of salt would be like 2 grams a day. And it's extremely easy for a non-scratch diet, like if you're eating out or you're eating things that come in a box or a bag, you know, things that are processed, etc. It's extremely easy to get to 2 grams a day. That's 2,000 milligrams of salt. You know, for people with NOH, sometimes we'll recommend increasing that salt to closer to 4, 6, or even 8 grams a day. So the salt tab is intended to supplement what's already in your diet in terms of 1 gram 1 to 3 times a day. And again, same idea, by salt retention, increase the fluid in the vessels, but same side effects. You can cause the blood pressure to go up lying down, and you can cause edema, including heart issues. So don't do this without the clearance of your cardiologist or your neurologist or other doctor. Caffeine can play a role by for people who have problems with blood pressure dropping after they eat a heavy meal or a meal in general. So what caffeine will do is it'll block vasodilation in the gut after meals. And that's something that, you know, you could have a cup of coffee with the meal or other forms of caffeine. But side effects can include tremor, jitteriness, insomnia, and cardiac issues. And then the more recent medication that's been co-opted to use for NOH is called Strattera. It's actually a ADHD or attention deficit disorder medications with a stimulant medication, but there's some data that the once-a-day use of atomoxetine can boost norepinephrine and boost the blood pressure, but it can cause nausea, constipation, stomach upset, dizziness, and insomnia. So that's all I had on my end, but obviously, you know, I'm here for questions and other thoughts. I think the trickiest thing, the hardest part about treating orthostatic hypotension is the issues that we get with supine hypertension. So a lot of my patients kind of get stuck between a rock and a hard place. And at that point, I'm looking just at symptom management and you know, safety. So I'm not necessarily expecting to see the numbers to normalize or even look that pretty, but as long as people are functioning well, able to walk around without passing out all the time, then that's sort of what our goal is.
Okay, great. We do have some questions. So let's see. How is supine hypertension that occurs in the night diagnosed? Is there a 24-hour blood pressure monitor, like a Holter monitor for heart problems?
That's a great question. You know, I had a patient tell me once that some of these newer Fitbit type things can do that. I'm not as familiar with that, but I had sort of heard a rumor floating around that. I don't know if it's the new iWatch or if it's some kind of, there's some newer monitor that can do that, I think. I don't have a name for you to tell you, but that might be something to look into. It's of course very different from heart rate per se, where the Fitbits and the iWatches and all of those are already very good at doing heart rate monitoring. But blood pressure, you know, the thing about blood pressure, as you know from going to get checked, is that you kind of have to compress something to then get a read on it. So you don't want to be like constantly opening and closing a blood pressure cuff in the middle of the night. I don't necessarily ask people to check in the middle of the night, but that's why I say, you know, you lie down 5-10 minutes, and that's usually enough for me to get a good sense of what's happening in the middle of the night.
Okay, very good. We'll do some research about that technology, and if we find anything, we can broadcast it out. Okay, we have Mark the cyclist. He loves to cycle, but his wife and daughter want to remove his bicycle keys. Oh, that's a good way of doing it. Because he sometimes feels dizzy upon descent during long rides. Mm-hmm. So, wow, Mark recently did 53 miles for the Tour de Fox and felt quite unsafe and dizzy at about mile 45. Then he rehydrated and felt better. Is that NOH?
Do you have NOH in other contexts?
Okay, here, Mark, I'm going to unmute you so we can...
I didn't know there were bicycle keys.
Yeah, I'm thinking maybe like a bicycle lock.
Yeah, I figure, yeah.
So, Mark, are you out there? I unmuted you, so you should be able to talk on your own behalf.
Or you could type. I can see the chat on my screen. So
Yeah. So he said he had PD for 9 years with yes, but he's on Flomax.
Well, if you do have orthostatic hypotension, then you should talk to your urologist about other options other than Flomax. If you don't have orthostatic hypotension, obviously, the dehydration is extremely likely. I mean, when you're on a 53-mile course. So if that's your only symptom, you don't get dizzy any other time, then it's probably not NOH, and it's probably just dehydration. But keep in mind that this is like a stressor, if you will. So it's like if somebody is completely normal and they have completely normally functioning nervous system and they ride for 53 miles, they might get dizzy just from dehydration. But if you have Parkinson's and your nervous system isn't exactly up to par, then it might not take as much to get you dehydrated. So you might need to be, even proper hydration might not exactly be enough in that context. What you could consider doing would be to talk to your urologist about holding the Flomax a day or two before your ride and see if that helps. But I don't know that, I certainly think that you should do whatever you can to keep biking because it's such a great exercise for you.
Yeah, so tell your wife and your daughter.
Well, talk to your doctor first. Make sure that you've done a few checks like this. Like I said, get a blood pressure cuff at home. Check it a few times at home on your own. And if it's fine, then maybe think about what the Flomax is contributing on the day of the rides. Okay. And obviously stay really hydrated. Make sure that as you're hydrating, you're also getting salt. I'm sure you're already aware of that. If you're a long distance cyclist, you're probably aware of the importance of salt and potassium and mag and all of that kind of stuff.
Okay. And you bring up a good question because a lot of times there are multiple physicians involved. Like we've talked about urologists, cardiologists, neurologists. So which doctor should people start with? I mean, the neurologist, or how would you recommend that people kind of tackle this with multiple docs?
So that's a really great question because you don't want to have too many cooks in the kitchen. It kind of depends on the comfort level of your treating clinician. So I feel comfortable managing the problem of orthostatic hypotension. So I ask my patients to bring their logs to me. I look at it. I manage their midodrine or Florinef or Northair or whatever it is. So I feel comfortable that if I have somebody who has a cardiac issue, like heart disease, heart failure, etc., then I'll ask them to get an opinion with the cardiologist to verify that they're okay with us, making these adjustments. But if somebody's neurologist, some of the, non-Parkinson specialists are a little bit more like, oh, well, I only want to deal with your Cinemet, then they may not feel as comfortable with it. They may want to defer to the cardiologist. And again, even within cardiologists, there are some who have more interest in this issue, and specifically those who have that autonomic nervous system, autonomic cardiology background. They might have more interest in this and more kind of ability to manage it. As regards to urology, I feel like my role in the urological symptoms of Parkinson's and therefore the management of the meds is for me to be aware of what the symptoms and or meds can be and can do, and then I do not touch them. So if I don't want somebody taking Flomax, I ask them to connect with their urologist and or see a urologist, or if their primary has been giving it, their primary, and to discuss adjusting that or switching it out or whatever. But I don't touch those meds just because Parkinson's isn't the only cause of urinary dysfunction. Obviously we just talked about the prostate. In women, it's the pelvic floor dysfunction. So I don't want to assume that things are purely from Parkinson's and medicate or what have you when they should be evaluated for a structural issue like prostate cancer or prostate enlargement. I also should mention that a lot of cardiologists get really worried about the role that levodopa has in causing orthostatic hypotension. And, of course, for most of my patients, I can't really lower that too much. So that's, of course, something that I bear in mind. But again, it's a dialogue, I think, in an ideal world.
Okay. And Bob wants to know if NOH is more likely in advanced Parkinson's, or can it happen in early Parkinson's? Does it have anything to do with years after diagnosis?
I think it can happen more frequently as the disease progresses, but I think it's less common in the earlier setting or in the years before it can occur. Certainly, there are people who will manifest with that before they manifest. But I think if there's a very prominent, a lot of orthostatic hypotension and not so much Parkinson's, then I'd be more worried about a different condition called MSA. MSA is multiple system atrophy. That's not to be confused with multiple sclerosis. They are completely different diseases. But MSA can look very much like Parkinson's, but it can manifest with a lot more autonomic dysfunction, namely orthostatic hypotension, or the kidney, the bladder dysfunction, constipation, swallowing problems, etc. And it is a much trickier disorder. It's at this point how we manage these conditions is symptomatically, meaning we give the same kind of medications for both MSA and PD, but it's more of a question about prognosis, and it just gets trickier. So that would be my concern if somebody's having a lot of orthostatic hypotension right off the bat, minimal Parkinson's, or only, before the Parkinson's begins, then we worry about MSA. MSA used to be called Shy-Drager syndrome. You may have read about that, heard about that, but we don't really use that terminology anymore.
Okay. Mary shared that last year her husband fell and had to go to the ER, and it was a nightmare, and she thinks it might have been due to NOH. So I guess that's more of a comment, but it can, it can have some pretty serious consequences.
Absolutely. Yeah, absolutely. I mean, hip fracture, subdural hematoma, like bleeding in the brain, these kinds of falls, the trickiest cases are the ones where patients don't have a warning. I have a few patients where they're fine. They're like, there's nothing wrong with me. I don't know what you're talking about. I'm totally fine. And then, their family members are telling me that they're passing out, or they're looking like a zombie, or, all of a sudden they get up, and they don't think about slowing themselves down, and then, they're on the floor and blood is everywhere. So it can be extremely dangerous. I don't want to alarm people, but yes, it can be very problematic. And the other thing, actually, I forgot to sort of put a slide in, was talking about okay, what do you do when somebody's looking like they're passing out? What do you do in that actual moment? And the key is, again, the problem is getting the heart rate up to the brain. The blood flow up to the brain. So you want to get people lying down. You want to put the brain and the heart in the same level as quickly as possible. So in as safe a manner as possible, you want to get people down, and you want to get the legs up. Because a lot of times what I've seen is people will say, oh, well, if you're feeling faint, put your head between your knees. And I've seen people, well, that doesn't quite do it. They still are passing out, and then they fall out of the chair, and then they hit their head on, as they're falling out of the chair. Or, they're just trying to sit up, trying to fight it, and they're sitting, blood flow's not coming. And I've actually had people have a seizure because of lack of blood flow to the brain. So it's very important if you're with somebody, to get them down, legs up, or if you're by yourself, if you do recognize it, don't fight it. Sit down, lie down as quickly as possible. Again, move those arms and legs, very cold glass of water. Try to get as much blood flow back as possible.
Okay. And that's a good segue to Kelly's question. Could you re-explain then why you should stay out of bed during the day? So if
this would only be for people who are having supine hypertension. It kind of is like exercise, if you will, for the blood vessels. The more time you're spending in bed, the less time the blood vessels are doing in terms of working on getting the blood pressure up. So that's a general recommendation.
Okay. So if there is an episode.
And this doesn't mean like don't nap. I mean, if people need to nap, they can nap, half an hour or whatever. But, you don't want them to be like in bed all day long.
Very good. Good advice all around. Okay. And then Lisa had the question, is it better to take blood pressure during the peak dose or the end of dose of Cinemet?
I would say peak dose.
Peak dose. Okay. And then I guess this kind of goes back to the ER comment. So, and I guess you wouldn't know, but do ERs and ER doctors know about NOH? I know that you can't speak on behalf of every ER doctor ever, but I guess maybe what I would take from this is, in the ER, they're looking to, save your life, cover the basics. So maybe as a patient or a care partner, you need to advocate for yourself.
Yeah, absolutely. I mean, definitely if it's something you've seen happen before, he gets dizzy, you can mention he's got Parkinson's, his blood pressure drops. Can we just check his blood pressure lying down, sitting, and standing? They will not routinely do it. They have to think about it to check the orthostatics, but they'll often do it. If somebody's coming in looking dehydrated, they'll check the orthostatics. Sometimes if they call me, I'll say, please check orthostatics. But certainly it's something you can bring to their attention. But I've certainly seen people where they look so kind of dead and zombie-like, where people are thinking that they're having a stroke or a seizure or something like that. And then it's like, well, let's get them head down, get the legs up, so those are the basics that I think of. And then if that's not getting better, then, maybe they should be in the ER and be evaluated for for a stroke or something like that. So again, we want to be aware of what can manifest, but not miss other things just because somebody has orthostatic hypotension, especially since supine hypertension can increase the risk of stroke.
Okay. And talking about someone being very pale, looking zombie-like, you mentioned before that people don't always necessarily pass out when they have their blood pressure drop. So sometimes they could still, you said they would just kind of get a blank look, or what does that look like? Is it most common for people to pass all the way out, or, what warning signs should you be aware of, as a care partner watching your person with Parkinson's? Obviously, if they pass out, that's noticeable.
Right.
What if?
So it's kind of going back to what I said earlier in terms of lightheaded, dizzy, foggy, blurry vision, tunnel vision. If you're looking at somebody and they're kind of like dazed, or like they're not responding to you, that's when I would say, like maybe get them lying down or check their blood pressure. I think what I would say is I'll flip that question around and I'll say, what are the warning signs for something very serious like stroke? And I would say if there's, weakness on one side of the face. So that acronym of B FAST is the newest acronym there. So the B stands for blurry vision. So if they're complaining of loss of vision on one side, or double vision, sudden onset. The E is, they've changed it. What was the E? No, the E was eyes. The B was balance. So if they can't stand up, E was eyes. F is face. So loss of strength on one side of the face, like facial drooping. The A is arms. So see if they'll put their arms up if one arm is like drifting down. The S is speech, if their speech is slurred or coming out completely garbled, and the T is time. So with Parkinson's, there's so much like gray zone and unclear, but if I would say when in doubt, kind of err on the side of precaution, because unfortunately having Parkinson's doesn't prevent stroke in any way. It doesn't protect you from having a stroke. So I think the things to look for would be, is it something you've seen before? Can you just get them lying down and they're responding right back to normal? Check their blood pressure. You don't always have to jump and run to the ER for every time this is happening. I think the ER visits would be more for, if there's an injury or if they're not responding after those sort of basic things at home. I guess that's all I'm going to say about that.
Okay, great. Okay, we had another question back to medication. How do you, so I'm wearing stockings, I'm taking additional salt and drinking caffeine. How do I know whether it's time to start medication or it's okay using the non-medical route? I always prefer not to take medication that I don't need to.
That will depend on your symptoms. If you're walking around feeling okay, not getting lightheaded or dizzy too frequently, or if you have that lightheadedness but you can manage it, you can like take your moment and feel like you're relatively okay. If you're looking at your blood pressure log and there's not so many drastic drops, then I would say you'd probably be fine off of meds. But again, that's a decision between you and your doctor.
Okay, and you mentioned that you give your patients a blood pressure log. Is it just as simple as, I mean, does it have additional?
It's got columns, so it's like the date, supine blood pressure, standing, lying down. I'm sorry, now I'm mixing it up. Supine, sitting, standing, so that it's in the order that you should be doing it. And then the last column is symptoms. Because if your blood pressure is dropping but you don't have symptoms, and again, it's sort of going back to what this person just asked, like I'm not necessarily going to medicate that. But if it's like I'm feeling dizzy a lot, or I almost passed out, or he was looking like he was a zombie, then I would say, okay, that's more informative to me.
Okay, very good.
What I don't have on my log is pulse, because for the vast majority of people, the pulse stays the same, so I don't necessarily need to see that in all the three. But if people are having blood pressure issues, heart rate changes, then they can keep that information. The other thing I liked about the log that I created is that it's about, I guess, 3 weeks on one page, so it's easy for me to see. It's kind of in a clearly written. I had patients come in with these tiny little notebooks that they were keeping in, and I'm like flipping through it and I'm like, I can't make sense of this. So I like it sort of where I can see all the columns, so that it's like my eye can look at it quickly rather than underneath each other. It's harder for me to read. So that's my personal opinion. It's not the end of the world if you have your own log. I mean, whatever log you like to keep is fine, but it's easier for me to read it the way I've done.
Okay. Would you maybe be able to email it to us? Okay, it's not proprietary to your practice or anything?
I mean, I made it myself, so it's not, and I didn't pay anybody for it.
Okay, thank you. That would be,
Sure,
in case people don't have that, that might be a good place. And I'm sure if you like the data like that, then probably most physicians would as well.
Should I send that to you, Andrea?
Yes, please. And okay, so we have another question from Nelson. I'm considering DBS. Would DBS have any effect on NOH? That's a lot of acronyms there.
I'm gonna have to look into to see if there's been any recent data on that. I don't think so. I don't think it would do it yay or nay. Like, I don't think it would have an impact on that. But I can
probably not the only reason that that he's right, Nelson?
No, yeah, I'm sure it's not the reason why he's considering it.
Okay, I guess just curious if if all the check boxes will be checked. Let me just make sure I didn't miss anybody's chat questions.
These are great questions, guys.
Yes. Our audiences always impress me with their level of understanding. If you gave me a test on your slides, I don't know if I would pass, but I bet our audience would know their neurotransmitters and how to take
There will be a pop quiz on how to spell norepinephrine.
Okay. I'm proud of myself for just getting neurogenic orthostatic hypotension right.
Right. Now say it 5 times fast.
No, it's kind of poetic though.
No, isn't it? I don't think people feel that way who are dealing with it.
Exactly. Just the word. No, I mean, I think this has been a great talk to to understand the why behind it.
Yeah.
Some easy tips. I mean, the fingers and the, you know, constricting your
Yeah, that
calves.
really helps. You know, take your time. That, you know, we call that isometric exercises, you know, especially in the legs. And even when you're standing and waiting for those like few minutes to before you get moving, like, you know, kind of marching in place. I mean, you know, if you think about people who pass out who don't have Parkinson's, like, you know, that traditional sort of locking your knees in church kind of thing. So like, don't lock your knees. Like, think about the, you know, the beefeaters, right? The Buckingham Palace guards are standing there for like hours on end. They're actually moving their calves. You can't see it, but they have to move their calves and keep the blood flowing. Otherwise, you'll have guards passing out. So, you know, it sort of same holds for the Parkinson's patients. Like, do move your legs if you're standing in line at the post office or whatever, you know. And then, of course, a lot of people will sort of take advantage of ways of not standing in line, whether it's online ordering or that kind of thing, so that, you know, you're not putting yourself in a position where you're likely to pass out.
Yeah, absolutely. These everyday life hacks, very important to keep everyone safe.
It's a good time it's a good time, I think, with a lot of the technology has really been beneficial for Parkinson's patients.
Yes. Okay, well, we covered all of the questions in the chat. So thank you everyone for your input and your attention. So we do have some follow-up items. I will send out that blood pressure log. You might already have one that you're using, but if not, it sounds like Dr. Petrosian created a good one. And if anyone has questions that they think of, you know, an hour from now that they forgot to ask, you can also email those to us and let us be your conduit to the answers. That's what we're all about at PMD Alliance. We want to connect people to good quality information straight from movement disorder specialists like Dr. Petrosian here. So thank you so much for generously sharing your time with us. We definitely appreciate all of this great information. So I will close out today's Lunch with Docs. And also, if anyone has other topics that you want to hear about, please share with us. We're, you know, very responsive, always, you know, willing to create a program to address questions and needs that you have. So thank you, everyone. And thanks again, Dr. Petrosian.
My pleasure. Thank you, guys.
Okay, bye, everybody.